Hello, my name is Dorothy Kozlowski, and I am a Vincent DePaul Professor of Neuroscience and Biology at DePaul University. And I'm also the co-founder and director of a group called the Illinois Coalition to Address Intimate Partner Violence-Induced Brain Injury. And I'd like to thank the organizers for inviting me to come and speak to you about this important work and bring it that is unfortunately not getting a lot of attention. So I'm going to be telling you about this intersection between brain injury and domestic violence. I am going to start though with a disclaimer, in that I am a basic scientist, meaning I have for the last 30 some years been studying traumatic brain injury in animal models. However, I had the fortune of going to a conference and chatting with a colleague of mine, Jonathan Lifshitz, about some work that he was doing looking at this intersection between domestic violence. And at the time, I was looking at doing concussion education for kids, how to play sports safely, et cetera, and realized that I could also use my expertise in this field of intimate partner violence, although I didn't know much about it. So I reached out to some colleagues, Sonia Crabtree Nelson, who I'm still currently working with, is a social worker who has done work in domestic violence for a very, very long time. And Doris, who unfortunately has left DePaul, so I'm going to focus on the work that Sonia and I have been doing. We started with 4 years ago now with a day-long conference on this issue and topic. And as you can see, it garnered quite a lot of interest in the Chicagoland area. And in the audience was our colleague, Kate Lawler, who at the time was the director of the Pathways program, which I'll tell you a little bit more about a little bit later, at Swedish Hospital. And since then, and this Pathways program rather, is a program that looks specifically to help individuals who are dealing with domestic violence, sexual violence, human trafficking, etc. And so Kate, myself, and Sonia, and also now Maria, who has taken Kate's place as the director of the Pathways program, as Kate has gone on to a different position within Swedish Hospital in North Shore. We banded together to form this group called the Illinois Coalition to Address IPV-Induced Brain Injury. We also belong to a national group of individuals who are looking at the neurological epidemic in abusive trauma. And these are individuals who are in Phoenix, Dr. Hanmaker and Lifshitz, and then also Ohio, Dr. Nemeth and Rachel Ramirez, New York, Kathleen Monahan, and then at Boston at Harvard Medical School, Eve Valera. And I'll be telling you a little bit about some of the work that we've been doing as a group as well. So with that sort of introduction, what am I going to talk to you about today? I'll give you some background on domestic violence, a little bit of background on brain injury, and then provide you with some data regarding this intersection and how we can perhaps better serve the needs of this population. So intimate partner violence is sort of the more academic term for domestic violence, but it's more commonly referred to as domestic violence. But it's basically behaviors that are intended to exert power and control over another individual. This includes physical, sexual, verbal, emotional, and financial abuse, and most recently, stalking. In the context of our conversation, we're going to focus more on physical and sexual abuse. I'm going to refer to these survivors mainly as women, but only because they are typically women, but not exclusively, right? So we also see this issue in men and also in the LGBTQIA+ community. However, the data that is most available is data focused on women survivors. What we also know about intimate partner violence is that those who are minorities or lower in the socioeconomic status are at an increased risk, as are also female veterans. And the abuse can kind of spill over. It can involve abuse of the elderly or older individuals or children in the home as well. And I don't think I have to tell you all, I'm sure you understand that COVID has really changed a lot of things. And unfortunately, it has increased the prevalence of intimate partner violence. Okay, so now let's talk a little bit more about brain injury. So in the context of domestic violence, brain injury is going to take on two forms. It can be traumatic brain injury, where in this case, your brain your head is being jostled. So you're either being hit in the head or hit in the face, or your head is hitting some other surface, and your brain is being jostled around in your cranium. In the context of domestic violence, you can also experience brain injury due to strangulation. So when someone is strangled, it basically causes a lack of blood flow to the brain, and this lack of blood flow to the brain can lead to hypoxic or ischemic changes in the brain that can lead to a lot of symptomatology that is similar to what is seen in traumatic brain injury. So just to make sure we're all on the same page and we understand how the nervous system works and what happens when it's disrupted due to either traumatic brain injury or strangulation, I'm just going to briefly give a quick overview of normal neuronal function, right? So our our cells in the brain are called neurons. And the idea here is that there's an electrical signal that's going to arrive at one part of the neuron. It's going to get transmitted down this axon, sort of like a long telephone line or a long electrical line. And when it reaches the other cell, it's going to release chemicals. And these chemicals are neurotransmitters. You've probably heard of dopamine, for example, in addiction, or serotonin in depression. These neurotransmitters then chain and can interact with the next neuron, the next cell, and allow that transmission to go to the next cell and the next cell. Sort of like a very complicated game of telephone, though using billions of connections and cells. The way we function, though, is that these neurons organize themselves into systems. So here you see systems that use dopamine, and you can see these arrows pointing to all the different tracks and pathways, kind of, thinking about it as like a highway system. And so if you follow the track from this origin to here, that might have something to do with organizing your thoughts, or from here to here will be in charge of organizing your movement. Okay, so these systems can be disrupted when someone is strangled or hit in the head. And so what can happen in both instances is that during injury, your brain can release ions that it's not supposed to, like potassium, for example. And the ions can be replaced with calcium. Now, calcium is great for your bones, but in the nervous system, too much calcium is a bad thing. And too much calcium can cause a massive release of neurotransmitters, which can interfere with cell communication. So think about yourself when you're bombarded with all this input, all this information coming all at once. It's kind of hard to process, right? Similarly with the nervous system, that it gets overwhelmed. During this time, though, the cell can be really, really vulnerable. And so if a person is hit again or strangled again when the brain is still dealing with this type of metabolic energy crisis, it can cause further cell death. And that's what's happening with things like repeat concussion or repeat strangulation. It can recover. It can take many days to weeks, depending. However, once again, if it's hit again or strangled again, it can basically make things worse. And we'll talk more about that soon. So with traumatic brain injury, what can also happen is that the connections, the axons that go from one cell to the other, when your brain is jostled around in your head, it causes those axons to stretch, right? And if you think about a piece of licorice, you can stretch that licorice to a period of time, but eventually it can break, right? And that's called shearing. of an axon, okay? And when that happens, you can basically, think about it as, a traffic jam on the Kennedy trying to get from downtown to O'Hare, right? The message can't get across, it takes longer to get across, and that's going to cause some dysfunction as well. So when I said that our brain is organized into these systems, when you're strangled or when there's a traumatic brain injury, basically you're going to be disrupting these different circuitry. So when a healthy brain is thought of as being wired for thought, an injured brain is basically having all of these different broken circuits. And depending on where the circuits are broken, where the dysfunction is happening, it can lead to all kinds of different neurological symptoms. It's probably hard for you to see all of this, but there's a variety of physical symptoms, things like headache, nausea, vomiting, sensitivity to light, sensitivity to sound, trouble with sleep, either sleeping too much or not sleeping enough, trouble with thinking and remembering, so difficulty concentrating, difficulty remembering where you are, what you're supposed to be doing, feeling foggy, and then difficulty with your mood, so being more emotional, being irritable or sad or depressed or nervous. Now, if you think about it, these are all symptomatology that, many of these symptoms are things that maybe you and I have had to experience. And if you're someone who works with victims of trauma, you realize that the trauma themselves can cause some of these symptomatology. And so how do you tease out what's due to a brain injury and what's due to other forms of trauma? And the way we like to think about it is that if someone's symptoms come on after an abusive incident, or if they worsen after an abusive incident, then it's most likely the symptom is due to the abuse. Now, there's not a magic pill for brain injury or for strangulation, but these symptoms have treatments. As you know, there's medication that someone can take for pain or depression, or anxiety, or for sleep. And there's also therapies, right? Physical therapy, occupational, speech, cognitive, and psychological. So there's things that can be done, but it's very individualized. Each person is probably going to need a different type of treatment program. And we'll talk a little bit more about that in a bit. Now, I mentioned repeat concussions. So these are very timely. We've been talking about them in professional sports like the NFL. The idea here is that with a repeat concussion, you have multiple hits to the head over a period of time. And when you do that, it's going to prevent your brain from healing because it's injuring already vulnerable neurons. And there's data that demonstrates that the multiple hits to the head over a period of time can lead to longer term deficits. And it's been demonstrated to be linked to an increased risk of neurodegenerative disease, specifically things like Alzheimer's, Lou Gehrig's disease, Parkinson's, and CTE. CTE is something called chronic traumatic encephalopathy. It was initially a term that was focused on boxing and boxers. It used to be called punch drunk syndrome. But in 2000s, Dr. Bennett Omalu demonstrated that this CTE was present in a former NFL player who committed suicide. And the pathology that you see here, so this is a slice of your brain. This is a normal, quote unquote, brain. And this is a brain that's been stained with something called phosphorylated tau, which is a marker of chronic traumatic encephalopathy. And you can see that there's definitely a significant amount of this throughout the brain. And that's what Dr. Omalu initially saw in this individual. And since then, he and colleagues, especially Dr. Ann McKee at Boston University, have done a lot to demonstrate that there is a definitive link between multiple hits to the head and this disease. Okay. So a lot of the work on repeat concussion and brain injury in general focuses a lot on professional athletes and soldiers. However, women and children that are impacted by intimate partner violence or domestic violence are actually more likely than the general public to suffer a traumatic brain injury. And that was brought to the attention here in this Huffington Post article back in 2015. So in our eyes, and my colleagues and I's eyes, we demonstrate that intimate partner violence actually intensifies the impact of a traumatic brain injury as a healthcare epidemic. 1 in 4 women experience intimate partner violence in their lifetimes in the US, so that's about 30 million women. In the world, the World Health Organization demonstrates 1 in 3 women experience IPV. We have data that demonstrates that up to about 90% of survivors receive facial or head injuries during violent episodes. Okay, and it's probably more than that because it's underreported. So if you just look at the United States, and you take about 90% of 30 million, we're talking about 27 million individuals who are likely showing signs and symptoms of brain injury. So our group likes to call this a diagnosis of exclusion. If you interact with someone who is a survivor of intimate partner violence, it's probably good to assume that there is some brain injury involved. Okay. We have data that demonstrates that the prevalence of brain injury in the context of domestic violence is about 11 to 12 times greater than the published incidence of brain injury from just regular occupational, recreational, and accident events. And the problem is that the majority of survivors who show neurological symptoms don't seek medical care. Okay. When we talk about strangulation, in the context of domestic violence, it's a very lethal warning sign. It's pretty common. 68% experience strangulation as a component of abuse. And the problem is that there's not, significant external signs of injury. We talked about how strangulation causes a lack of oxygen and nutrients to the brain, and that these symptoms are similar to those that are seen following traumatic brain injury. And similarly, the majority of survivors who show neurological symptoms post-strangulation don't seek medical care. Okay. So I like this quote from Harper Lee, To Kill a Mockingbird: "You never really understand a person until you consider things from his or her point of view, until you climb into his skin and walk around in it." So I'm going to take a quick second and show you this victim story. I'm going to stop sharing for just a quick second. Okay.
I'm Allison. I'm just your normal, average, middle-class soccer mom. If you saw me walking down the street, you would think everything is fine with me. But it's not. Not anymore.
Traumatic brain injury is known as the invisible disability, which means you will not see someone typically with a bandage on their head. That does not mean that they have not sustained an injury to their brain caused by a hit, a fall, being thrown down the stairs, or being shaken vigorously. It's invisible, you can't see it. They don't wear bandages on their head. Instead, we have to look for the symptoms that occur afterwards that were not there prior to.
When I had my first concussion, I didn't even know that I'd had one. I had the nerve to walk away from my ex-husband before he was finished talking with me. And he came up from behind me and pushed me, and my head snapped backwards. The next day is when the headache started. if I had known then what I know now, I might have handled them, thought about them differently.
So many times.
Okay, so hopefully that gave you a little bit of perspective on an individual who experienced head injury due to her violence. One thing I will say about that clip is that the data that's there is a little bit outdated. So, sorry, I'm having some technical issues here. Yes, so the data is a little bit outdated. Okay, so back to the presentation. Okay, here we go. Okay, so in addition to the neurological consequences of a brain injury, secondary domestic violence, these individuals also have other symptoms. They can have GI issues, they can have genitourinary symptoms, symptoms that indicate strangulation, psychiatric symptoms, and other common symptoms as well. And like I alluded to, some of the symptoms that you would think of as being due to traumatic brain injury are ones that overlap with symptoms that someone may experience if they have post-traumatic stress. So the issue here is just remembering that if the symptom is new and it happens after the injury itself, or it worsens after the injury, after the trauma, then it's most likely due to the brain injury. So there's other outcomes that are worse in survivors of domestic violence, that in addition to the physical and mental health outcomes that I just mentioned, there's increases in use of tobacco, alcohol, pain medication, and drugs. As you are probably understand, there's abnormal relationship function. And there is data to demonstrate that if someone has been abused, they themselves could have a higher risk of being an aggressor or perpetrate abuse themselves. And if you think back to the data that I showed you about repeat concussions leading to CTE, it's very likely that there are long-term neurological consequences in survivors of domestic violence who have received multiple hits to the head or multiple strangulations, something to the kin of CTE. And there was a study back in 1990 that looked at a case study of a wife who had been abused by her husband for a very long time and had demonstrated pathology of the brain that looked like quote unquote punch drunk syndrome, which is now referred to more commonly as CTE. So that was back in 1990. And then now recently, or more recently rather in 2021, another case study, and this time it's a 29-year-old with a history of domestic violence, and her autopsy was consistent with multiple brain injuries and pathology here that looks like, or that's phosphorylated tau, the chronic traumatic encephalopathy. Okay, so our goals in the coalition are to educate survivors and the professionals who work with them on this intersection. We also work to translate, transform, and treat using what we know about brain injury in athletes in the military to develop and validate effective approaches for survivors of IPV. And then lastly, to add to the body of literature on the subject. So this is just a little PubMed search that I did from 1995 to now for brain injury and domestic violence. And as you can see, we're not talking millions of studies, but there are increases. We've got about 58 studies now in 2022. If you do, like I said, the term intimate partner violence, that increases by a little bit more. So there is more work being done in this field. And my colleagues and I were asked to be guest editors of the Journal of Aggression, Maltreatment, and Trauma. And we produced a 2-volume issue on this intersection between traumatic brain injury and domestic violence, which you can refer to here if you're interested. And then our colleague in Boston, Dr. Eve Valera, she and her colleague, Dr. Colantonio, co-edited a special volume here just in January and February of 2022 of the Journal of Head Trauma Rehabilitation. So these are 2 sources for some great studies if you're interested. So what are the implications of this intersection? Well, as I alluded to earlier, most survivors of intimate partner violence are not aware that their symptoms are due to brain injury. But their symptoms can affect their initial interview by police and paramedics. If police and the first responders are called to the house and the person is not responding or not wanting to talk to them, it may not be that the person is difficult. It may be that the person is having trouble hearing them, or is just overwhelmed by the visual stimuli, having trouble understanding them, etc. And then the ability for someone with domestic violence to access services, to follow instructions, fill out forms, follow through with appointments. These are all difficult for them to do. And then lastly, due to the cognitive changes that may occur, their ability to make decisions regarding their family and the abuser may be impaired. So brain injury is not an easy diagnosis, especially in domestic violence. So there are 2 tools that are there. Well, we know that brain injury just in the ER, in the clinical world, is not easy to always diagnose, right? Imaging doesn't always see it. There's not a good blood test you can take for it. But in the context of domestic violence, it's a little more difficult. There are 2 tools. One is called the HELPS tool, which you see here. This one's a little more outdated because it talks about concussion, and consciousness, the loss of consciousness, and a loss of consciousness is not required for brain injury. So we are recommending this new tool that our colleagues in Ohio have developed, and they're actually working on a study to demonstrate its validity and utility, called the CHATS tool. And it asks simple questions like, have you been choked? Have you been hit or hurt in the head? After you were hurt, do you have any of these symptoms? Are you having trouble with any of these symptomatology? And then have you seen a doctor regarding it? So these tools are available. Other more new data about this intersection is in the context of neuroimaging. Our colleague, Dr. Valera, is basically the only person who has done studies on imaging of survivors of brain injury and domestic violence. And these are only 2 studies that demonstrate this. The one on the left here is looking at the resting state functional magnetic resonance imaging and neuropsychological measures in about 20 women who are survivors of IPV. And what you see here is that the severity of the brain injury was associated with a reduced connectivity within a network of the brain that's responsible for memory and learning. And these women were followed up in another study looking at DTI, which is diffusion tensor imaging, which is a way to look at their white matter integrity. And basically, similarly, their brain injury score, the higher the score, the excuse me, I'm sorry, the severity of scores were negatively associated with the fractional anisotropy, the FA, sorry about that. It's the measure of white matter integrity in DTI, okay? And this was done, once again, in areas of the brain, the posterior and superior coronary radiata, which are areas of significant cortical connectivity. So there's definite data out there that this is an issue. There's treatments available for brain injury, but the problem here is that there's access to services challenges. The access to services are challenging for individuals with domestic violence as their issue. And it has to be individualized, right? You need specific medications, specific therapies that's fine-tuned towards you. But there's barriers to treatment, right? There's in the population of survivors, there's a general mistrust of the health and legal systems based on past interactions or advice of the perpetrator. If you are someone who has children and you are diagnosed with a brain injury, that may be a consequence then, and may have trouble. You may have trouble then keeping guardianship of your children. Okay, rightfully so. Survivors are going to choose resources that ensure their safety over healthcare, and we all know COVID has demonstrated this to us. Even though it was there before, that there's healthcare disparities, there's inequity in access to services. So providers who work with individuals can benefit from becoming educated on the needs of the survivors with possible brain injury. Okay. And like I said before, access to services to address brain injury are challenging to someone who has a brain injury, because it makes it challenging for an individual to make appointments, find care, follow up, etc. The other issue is that concussion clinics in the area typically focus on sports concussion. So there's lots of wonderful concussion clinics in the area, but they really do, they're geared more towards the athlete that's coming in looking for treatment, not necessarily a survivor of domestic violence. Okay, and the focus on in athletes is this, treatment called return to play, right? So trying to slowly increase your activity until you're symptom free, doing the activity that you want to do again, if it's playing football or soccer, etc. But in the context of intimate partner violence, this graduated return, this return to play, for example, it's not feasible. Okay, so there's been data that demonstrates that a community of care is necessary that takes into account the special needs of individuals with intimate partner violence. They have unstable social situations. They may need transportation, childcare. Once again, they're going to prioritize safety over healthcare. They may have difficulty managing their care due to the brain injury and the influence of the abuser. So approaches that are being established for this population need to be very multidisciplinary and team-based. And most importantly, it requires a guiding advocate. Our colleagues in Phoenix have put together a program where they have been training individuals, starting with first responders, in this intersection of brain injury and domestic violence, so that they know specifically the needs of individuals who may be victims of domestic violence. And if they are, and they agree to it, they are then connected with a social worker who helps them connect with the appropriate medical facilities, the medical treatments, etc. Once they have a plan of care, then there is a different advocate in the medical system who helps them connect with their different therapies, etc., as well as connections with the legal community. I don't have time today, but there is a nice little Today Show segment on how this is working in Phoenix. In Illinois, we don't really have something like this, and this is something that our coalition is looking into. So if you're someone who is a healthcare provider and you'd like to learn more about this, please contact us. However, our Pathways program does come the closest to having this continuum of care for individuals who are impacted by domestic violence, as well as sexual violence and human trafficking. And what they do is they provide crisis intervention, they do resources and referrals, and then they focus on connecting them with individuals in the North Shore system to provide them with trauma-informed healthcare. Okay. So like I said, our coalition, we have 4 pillars. The services pillar here is something that we would love to expand beyond what Swedish does. Swedish does a wonderful job, but they do not have the capacity to deal with the exorbitant amount of individuals who would need this kind of care. So we're hoping to establish something like that in Illinois. Additionally, our coalition focuses on education. So in addition to speaking to you all here at this conference, we do 40-hour trainings for domestic violence advocates, medical advocates, shelters, etc., as well as grand rounds training. We're conducting research. We're working with folks at Swedish to get actual data on individuals that they've been working with and how many of them actually can be diagnosed with brain injury, and then advocacy as well. We work with our partners in Ohio at the Center on Partner-Inflicted Brain Injury because they have wonderful resources. They have resources for practitioners. So some of you listening to this may be someone who works with survivors of domestic violence. If so, everything I've talked about today can be found in this booklet here. And also they have wonderful guidelines for accommodations. So how, if you are working with someone who is a survivor, how can you accommodate your work with them to deal with some of their symptomatology? And this booklet provides you with way more than what I'm going to give you today, but the accommodations can be very simple. So just being mindful of symptoms, dimming the lights, working in a quiet, distraction-free area, working on shorter sessions, repeat, review, and check in, give very concrete instructions, and then follow up. And for the sake of time, I'm not going to go through any more specific accommodations, but that pamphlet that I mentioned is one where you can, get more focused on, well, if they're having difficulty with attention versus memory versus executive functioning versus processing info. Okay. There's also some other resources that I'd connect you with. Canada has a wonderful nationwide website here that you can look at called Understanding the Intersection of Intimate Partner Violence and Traumatic Brain Injury. It's the Abused and Brain Injured Research Lab. And then Pink Concussions is also has some groups that focus on, of course, women in concussions, but then a subgroup that focuses on survivors of domestic violence. We also have resources for survivors. We have booklets and cards and things to help them manage their own symptomatology. We have these cards here that we've been placing in domestic violence shelters as well as emergency rooms in the Chicagoland area. If this is something that you're interested in, please email me here and I'd be happy to send you hard copies, or you can download them from the from either our website here, okay, or the Ohio Center on Partner-Inflicted Brain Injury as well. Okay. So these tools that I mentioned here, one of which is this brain injury education card, are being examined in terms of how helpful they are. In Ohio, our colleagues there have provided these tools and this training to about 5 domestic violence service organizations and evaluating how they're being used and how they are impacting their practice with survivors. And they're demonstrating to be quite beneficial, making individuals who are working with survivors better informed, as well as the survivors and the clients that they are working with. So I hope that I've provided you with a little bit of an understanding of what this intersection is between brain injury and domestic violence. And really, we are only at the tip of the iceberg, so to speak, on this issue. And there's a lot more to learn, and there's a lot more that needs to be done. So what can you do? Well, if your research or your teaching or your practice lends itself to examining this issue, you might want to contemplate it. And if you're someone who works with survivors, thinking about how you might implement something from what you learned today in your practice. If you're someone who's interested in learning more about this issue, you can join our coalition. Feel free to email me at this email here. So with that, I thank you. I thank you for your attention. And please also feel free to email me if you have any questions that I can answer. Thanks.